Good evening, everyone. Thank you for joining us. This is Dr. Ashkan Lashkari, MOASC president. Today, we'll be discussing our agenda tonight is discussing changes or highlights in the treatment of ALK rearranged lung cancers, along with exciting updates in the management of our ROS mutated lung cancer. We have Dr. Husain, our moderator and session leader, and we have two amazing panelists, Dr. Ignatius Wu from the University of California at Irvine and Dr. Karen Reckamp at the Cedars-Sinai Medical Center. Thank you, everyone, for joining us. And I also wanted to provide a recognition to AstraZeneca, who has helped providing funding for these webinars. Thank you so much. Dr. Husain, I'll send it to you.
Thank you, Dr. Lashkari. And really, it is truly a pleasure to have both Dr. Reckamp and Dr. Wu over here to discuss this important topic that we're going to highlight today, which is the management of ALK rearranged in ROS1 fusion mediated lung cancer. So I have, I've prepared some slides, and again, this is meant to kind of just provide a landscape discussion, and then also kind of take the opportunity with both Dr. Wu and Dr. Reckamp to really talk about some of the emerging trends and kind of quote unquote what's new in this ALK and ROS space. And so again, it's going to be quite interactive. Definitely welcome questions of all natures, and really kind of even case presentations, case descriptions can be helpful as well. So along those lines, actually, here are just some slides, and going to highlight the point here with putting it into like a screen mode. Okay. So again, this is titled as how one may treat ALK mediated lung cancer. And again, we're going to go through this hopefully in like the first half an hour, and then the second half an hour ROS. And again, there may be, we may spend a little bit more time on any one versus the other. So, we'll make it up kind of, with that. And so, we like to kind of start some of these by just, a discussion around, some major underlying principles as we think about, this subset of disease. Some of these principles kind of apply across other genomic subtypes. One of the things, actually, just to clarify, and this would be great, Dr. Wu and Dr. Reckamp, to kind of hear your perspective on, is for an ALK rearranged lung cancer, certain clinical characteristics or tools that help you to kind of get, a handle on this particular population. I think specifically, actually, things that I wanted to kind of go through are age. For a patient with lung cancer, how important is the age of that patient as you think through some of the components around help deciding the next therapy and such? Obviously extensions of that are smoking history and ethnicity. Are these clinical clues still in your practice driving ways that you frame some of your thinking? Or have you broadened your kind of thinking to kind of be really, let's not really focus on these demographic features. Let's kind of really just get genomic testing for everyone and not think through that component. Dr. Wu, what do you think about that?
I don't think age is that important in determining what to treat. You know my answer, but I mean it just gives you, if somebody's young, then it's just not good. That's the way I look at it. someone who's in the mid-30s or late 30s present with all positive lung cancer, that's just bad. Doesn't mean I'll use a more aggressive treatment. It's the same treatment. So I agree with you. I would go with the genomics, and the drugs are very tolerable. It's not dependent on age per se. There's really no, at certain age you have the dose reduce. So I'll stop here.
No, those are really important. But Dr. Reckamp, actually, your thoughts, actually, how important are those demographics still in your practice, now?
So I would agree that if you think of younger age, that really doesn't fit. We have plenty of patients who are, above 70 and have ALK or ROS1 altered non-small cell lung cancers. And we see that more and more. I have a ROS1 patient who has adenosquamous carcinoma. So it's not only adenocarcinoma. Still, generally, we see them in light or never smokers. So that's kind of the piece that does trump other things. But I generally don't take smoking status, doesn't exclude a patient from getting full genomic testing. And I think really when we think about ALK and ROS1, the one thing that sets people apart at their clinical presentation, which is not demographic necessarily, is that they often present with thromboembolic events. And that has been described with both ALK and ROS1. And it may be that their tumors are more mucinous and set off the coagulation cascade. But those thromboembolic events always clue me into that we may be dealing with a patient with ALK or ROS1.
No, that's super helpful, actually, and really important insight, actually, especially in light of the fact that you're really checking for PEs and kind of understanding that concept in this category of patients is helpful. I definitely, kind of agree and reflect on some of the things you've mentioned with the fact that I even just, recently saw an African-American patient with the ROS1 fusion, and really kind of thinking around, should we be narrowing our thinkings as we view these patients or expanding them? I mean, obviously across other targets, we have a diversity of ethnicities represented that can still have these aberrations, whether they be ALK and ROS. It's interesting, kind of sometimes I reflect though, that if we are seeing patients in their 30s or 40s with lung cancer, and we do certain genomic tests and we don't get a result that yields, a targetable mutation, really kind of begs the question that, really going deeper, making sure we're not missing cases, and specifically with certain types of testing, including RNA-based strategies, really kind of making sure we're not missing patients, particularly those that may, maybe ones that, that fall into this category. Molecular testing do employ.
Dr. Husain, I think your email is free, or your connection is going in and out. Can anybody else hear?
Yes, I can hear, but I agree.
It's frozen right now.
Okay, let me send him a text. Okay, so he's going to come back on in a minute.
Sorry about that, everyone. Are we still waiting for him? Perhaps I can help continue the conversation. I had a question for the panelists, and that is, I think that he was going to ask this question, and that was, how to choose between the different frontline options. And I know that we had some data that was presented about a year ago on the lorlatinib trial, I think the CROWN trial. I don't know what your thoughts are this year, if things have changed in terms of your practice patterns.
So I would say for myself, they have not. I am still have had challenges with toxicity with patients who are on lorlatinib, and so tend to use it as a in sequence as the next treatment. As I invariably am dose reducing lorlatinib, and patients are having a little more trouble staying on the full doses. So I have still used it as subsequent therapy post either alectinib or brigatinib, generally as frontline therapy. But Dr. Wu may have a different experience.
Yeah. Dr. Wu?
So I think the premise of the first question is that you are equating both are the same efficacy, which I disagree. Lorlatinib is a better drug. I predict the PFS will be greater than 60 months when the PFS is mature. Pfizer updated.
Can you remind our audience about the PFS in the first line use of both alectinib and lorlatinib?
The lorlatinib at 36.7 months PFS, median follow-up time PFS has not been reached. Alectinib at median follow-up time of 18.3 months, the PFS reached at 25.7 months. That's my blind independent review. So lorlatinib is 1 more year of median follow-up time, and the mature PFS is still not reached. They put 7 abstracts into last year's congresses where, due to COVID, whatever, there's a poster form that not many people are aware of. And then they published the data recently in Lancet Respiratory Medicine, which nobody can even subscribe to. I somehow break the code through, I think, UC Davis or UC California Library. I think when the mature PFS of lorlatinib is reached, then we will know. Right now, because we don't want to acknowledge that, because there is no mature PFS, so we just kind of let's just wait and see. And I think the 3-year PFS rate of lorlatinib in the trial is about 63%. The 3-year PFS rate
That's very impressive.
was 43%. So I just think you can't give a 35 months of PFS. I don't think any TKI in the history of oncology can get you a PFS of 60%. Cross-trial comparison, different patient characteristics, but you really have to, lorlatinib is a better drug preclinically. It's like if you're buying a race car, how do you compare 0.0 to 60? What is the seconds? Porsche said they can get one at 2.2 seconds, and Bugatti said they can get one at 2.1 seconds. So, and then the Bugatti is faster than the Porsche when you drive it, and that's the reason why. The only reason I mentioned that because I went to ESMO in Paris, and I walked out the Peninsula Hotel, and there was a white Bugatti on the right side, and a black Bugatti on the left side, and then I took a picture, and then they have and then it all from KSA, Kingdom of Saudi Arabia, so they ship it there, the license plate. But that's the first time I've seen a Bugatti, and the last time I've seen a Bugatti. So,
well, I would argue though that again, lorlatinib has some of the best activity in resistant disease, and I have a patient who's been on lorlatinib post a first line, or first generation, or not first generation, but first line TKI, and has been on for 3 years, and so I'm not certain that using it frontline makes a difference, that you can utilize it later on. And so I think that I still think that the verdict is out. I don't think that it's a slam dunk for frontline. We have great treatments for ALK, which is really the best news, and that, you know, even no matter how you treat, the median survival is about
I
80
disagree.
months.
You can't use an anecdotal case to say that yes, lorlatinib can work, but the median PFS post second generation ALK is 5.5 months. That's the trial that got lorlatinib approved as a second line. If you add the PFS together, you still don't reach the frontline PFS of lorlatinib. We have to objectively look at the data and not, you know, use anecdotal evidence. This is the key. I mean, you look at 25.7 months plus 5.5 months is still less than what lorlatinib is trending at this point. And they also publish a PFS the PFS2 post Crown, and there was I think it's an ESMO poster that shows that the PFS2 post lorlatinib 3 years PFS is 73%. And it has not been published yet, but I don't think we can just say we have good drugs and then we ignore a difference in 35 months PFS advantage of lorlatinib.
No, I think that's really, you know, really an interesting, you know, discussion. And I think, you know, obviously great to hear, you know, multiple sides of the coin here on that. You know, Dr. Wu, you know, your comments about the PFS1 plus the PFS2, you know, I think are particularly interesting. Remind us again, actually, do you mind kind of, you know, detailing the PFS1 and PFS2 alectinib and then lorlatinib? You know, what does that equal?
Well, let's do alectinib in the blind independent reviews. 25.7 months is the New England Journal paper. The first publication, they already have a mature PFS of 25.7 months. I don't want to use investigator assess because that's just not. Roche tend to use investigator assess as a primary endpoint for a lot of trials, whether it's TKI, IO. So that's not as rigorous as independent review. 25.7 months, and then lorlatinib was 5.5 months in the second line setting post a next generation. If you look at brigatinib, we just published the Alter 2, it was 3.8 months post alectinib. And if you use brigatinib and then go to lorlatinib, the PFS is about 6 point some months. So you really need to maximize the PFS. You know, you can be lucky. I have patients who are on alectinib for 7 years. I'm not saying that alectinib is not good, but we don't know who will benefit. And the aggregate data shows that lorlatinib is the better drug. It's a better drug preclinically. It's a better drug that can get to the CNS. It's a better drug that proves itself on the ground data. I mean, it's hard because there's no mature PFS. So without a number, people will, it's hard to grasp this. I mean, we can have the same debate about which line, you know, chemo IO to use for Caspian versus IMpower 133. The difference is 0.6, so it don't really matter. But this is a difference of 35 months, so that's really matters. And even for that 0.6 months, I use Caspian when I see an extensive stage small cell, which I don't see. I see maybe once a year. R133, just because of that.
Can I ask a question, Dr. Wu? That is, you know, we asked Dr. Reckamp what her practice patterns were, and it sounds like she's still selecting alectinib as frontline therapy and reserving lorlatinib for second line. How are you? So you're saying that lorlatinib is a better drug. The evidence is better. What are you doing for a new patient that walks in your door with ALK?
It's lorlatinib, and I know people want a second opinion. If they have been on alectinib for 3 to 6 months, I still will switch them. You know, we just don't know who will benefit the most. So I do it. It's actually best to use lorlatinib up front because they don't have brain mets. You don't have a lot of SRS. You don't have a lot of the cognitive decline that could potentially with SRS. It's the best time to use lorlatinib is up front. Yes, I do it. I don't want to be evangelical for lorlatinib or zealot or whatever. So I just, well, so I don't want to, you know, if you comes to me, they know that I'm going to switch lorlatinib. If they want to switch, come to me. If not, you know, it's fine. I think lorlatinib is, you know, in 2 years' time, you will have the numbers, and then you can decide what is a better drug. Right now, we don't know. So, you know, we don't have a number because it's trending so slowly into the maturity.
And how do you manage the neuropathy and the weight gain that patients get?
If they have it, you know, we can exercise, diet. We actually try Lasix. Lasix is potential. Exercise, get a more healthy diet, more vegan diet. You can hold the drug for a few, you know, 1 to 2 weeks. It's not as bad, the weight gain. Eventually, you know, you can lower the dose to 75, but I do start with 100. That's another thing. I don't do 75 and then go up. I'm just, it's not that, I mean, trust me, you know, if we have given a worse TKI than, I mean, you know, we all have given poziotinib. I mean, Jesus Christ, you know, this is nothing compared to poziotinib or other drugs that really have a lot of side effects.
Hatem, I think we don't hear you yet.
Yeah, Hatim, yeah, we're not hearing you.
Oh,
All right, well, Hatim, Dr. Husain, are you, I think he's frozen again. I think we're all experiencing some Zoom issues today. Well, speaking of frontline therapy, perhaps we can transition to second line therapy. I think one of the, as you've mentioned, the beauties of managing ALK rearranged lung cancer is that the overall survival for these patients are relatively long, and patients can be managed from transitioning from one TKI to the next rather than switching mechanisms of action altogether. So perhaps we can hear from you guys how you would consider management of someone who progresses on frontline therapy. You know, Dr. Reckamp, you mentioned that you prefer alectinib. Perhaps you can discuss how you manage patients in the second line, whether they have new brain metastases or not.
So assuming that this is more diffuse progression and they don't have oligo progression, we use, a lot of local therapy for patients with oligo progression. But once it becomes more diffuse, then I generally do go to lorlatinib as my second TKI. After lorlatinib, I tend to go to chemo with pemetrexed-based chemo, as their patients have very, very good responses to pemetrexed-based chemo, and you get kind of limited responses to TKI after TKI versus a clinical trial. But often I've had success going back to TKIs after chemotherapy, and so that does prolong benefit as you get rid of resistance mechanisms. But I have not, even though there may be a 20% response rate or so with cabozantinib, I have not necessarily used cabozantinib in this patient population.
If I might just ask a couple of questions based on what you just said, you had stated that you switch patients to lorlatinib. Are you seeing that the PFS is around 6 months in the second line setting, or in your own personal practice, or are you seeing patients typically do better?
So I think that, there's still a very heterogeneous group of people that I've treated with lorlatinib. Some of them had received multiple tyrosine kinase inhibitors in the past and then gone on to lorlatinib. And I think, again, in my personal experience, the response is much longer than 6 months. So I have seen some shorter, but that generally is in second line plus, and there's a lot of data of multiply pre-treated patients and receiving lorlatinib and having very complex resistance mechanisms. So I think the data is still relatively sparse for patients who just receive lorlatinib after one TKI. And again, the other question is, do you look for resistance mechanisms? And we tend to look for resistance mechanisms, but at this moment in time, there aren't a lot of choices based on ALK, though we know that they may have longer responses and better responses if there is a resistance mechanism, a new mutation versus no identified resistance mechanism.
Okay. And perhaps I can just flesh out one other thing that you had mentioned, and that is the use of targeting areas of oligometastatic disease with radiation while keeping patients on the same TKI, for example, the frontline TKI that they're on. Is that something that you're getting a fair amount of benefit from? I mean, is that something that we should be considering in the community based on if we're seeing patients have, one area of progression? Is that something where, this type of disease and this type of treatment that we're offering them kind of lends itself to that type of approach?
I think most definitely. I think that, they get a certain amount of time on each of these therapies. And if you can prolong the time on therapy, and there's only some sites that have resistance and other sites that are still responding, and it's encompassed in a radiation field or can be ablated or sometimes even surgically resected, that is definitely the way to go with the therapy. I think there's also, data that is emerging to even do early consolidative localized therapy for patients who may have oligometastatic disease or just a few sites of metastatic disease, that you might radiate those areas early on in their therapy and potentially have benefits. And again, the studies are still pretty heterogeneous in the types of patients that have been included. But certainly we're seeing longer progression-free time, which again, in a disease like ALK lung cancer, as Dr. Wu has pointed out, the progression-free time is an incredibly important marker for patients.
Okay, thank you so much. And I'll move it to you, Dr. Wu. What are you doing in the second line? Not sure if you have any patients who have started on lorlatinib and have subsequently progressed after frontline therapy, considering how well these patients generally do, but how would you approach these patients in the second line?
Yeah, I don't have any patients who progressed. The first line indication was just approved, I think, last year. But I agree with Karen that oligometastatic disease, you ask your radiation oncologist, you ask your interventional radiologist who can do some ablation, maybe a bone, maybe radiation. Sometimes you can even resect some of the solitary progression, especially if they have been on the same drug for a long time. Theoretically, if somebody progressed on lorlatinib, I think best, if you look at the abstract that was presented, ESMO, 1/3 of the only 26 patients progressed on the crown so far, their data cut. So almost 1/3 got chemo, 1/3 got alectinib, and 1/3 got other ALK TKIs, not alectinib. They merged the PFS together, so we don't know which is the best option. But they merged the PFS at 3 years. It's still 74% PFS. PFS rate at 3 is 74%. So I assume there's a difference in the 3 different approaches, broad approaches. But if you have still at the on target, I would do alectinib afterwards. Chemo is always chemo kills anything. That's the thing. It's kind of like radiation, kills a lot of stuff. So it's doesn't matter you have a ROS, ALK, whatever mutations you have. So that's a potential. And I usually add the chemo to TKI to continue suppression of the CNS.
Where does brigatinib fit in this continuum of ALK therapies, if at all?
It's unfortunate. I think it's fallen off. I think if you look at maybe the market share survey, it's probably under 10%. I think the Alta 1L data showing the PFS of 24 months really hurts brigatinib. I was expecting more, but the number turns out to be essentially the same or 1.7 months shorter. And now ESMO Asia this year, they presented the Alta 3, which is brigatinib versus alectinib in the post crizotinib setting. It's not, apples to orange comparison, but surprisingly, they both did pretty well at 19.3 months versus 19.2 months. So I thought brigatinib would blow alectinib off the water with the Alta 3 design, but it turns out it was a tie. It was 19.3 versus 19.2 months. So it was really, really surprising. So to answer the long answer to your question is, it's not, I don't know. I mean, most people start with alectinib. I hope I can convince a few to start with lorlatinib, but not many people are starting patients in brigatinib nowadays. So probably slowly fall off the curve, unfortunately, because this is a good drug, but it got delayed in the development.
It is interesting, Dr. Wu, what you mentioned about the concept of starting with lorlatinib and then in the Crown study, some people getting alectinib afterwards. It would be nice to see kind of more details there. Also, another question actually before I lost the sound component was, you had some interesting data about the fusion partner and how the fusion partner may be important in terms of the selection of an ALK inhibitor. Do you mind kind of giving us some information about that, as you've presented that?
Well, I mean, the fusion it's either variant 1 or variant 3. Most of the NGS company we use usually report that. Variant 1 is always better than variant 3. It's more sensitive to ALK inhibitors. Doesn't matter which drug. So it's not differential in the sense that because of variant 3, you need to use lorlatinib. Variant 1, you can use alectinib. I think I just used them. Pfizer did put an abstract out in ASCO. It's also a poster. I actually couldn't find it. I was there and looked through the board. I actually missed it myself. It's like there's too many people. But they showed that what we expect. Variant 1 works better than variant 3 for all tumor types. And variant 3 was better with lorlatinib than alectinib, but it's still not as good as, variant 1, the PFS was not reached for lorlatinib. Variant 3 was about 33 months for lorlatinib. So it's a little bit better than what they achieved with alectinib, but it's still, if you compare within lorlatinib, variant 3 is still more resistant. That abstract is in the manuscript form, but it's still not hasn't been accepted yet. They also look at p53 mutations, and p53 mutations is bad. I mean, it's a great equalizer. If you have variant 3 and p53 mutation, almost everybody did poorly in a sense that the PFS was about 18 or 19 months. The data for brigatinib was about 18 months. The data for lorlatinib was about 19 months, and that's a poster. In the same poster that was presented by Pfizer in ASCO, but
No, that's interesting. May I ask actually, are either of you aware of any studies like a FLAURA2, but for ALK? Is that concept of early integration of chemo something that you feel applicable in this space?
Well, I'm glad you're a believer of FLAURA2, so that's good.
Yeah. Well, we still don't know, but you brought up p53 and maybe kind of worse prognostic elements with the fusion partners and the co-alterations. How important are those now?
So answer a question like the Fed chair answers to the Senate. It's a good opportunity. It's an unmet need. It's a good opportunity to investigate.
No, really interesting. And,
Yeah.
and
I mean,
Dr.
I think
Reckamp,
that the part of the challenge with that is that patients do so well and live so long. And you really, to give both up front, you want to see survival benefit, because if you're just prolonging progression free, but you're adding chemo right away, they're going to do well on chemo later on. I think to prove that survival benefit is a huge study, and I can't imagine it could be done. So I don't know, they do so well on so many therapies, including chemo. At this point in time, I'm not a fan of giving all of the therapies at once.
really important
Can I ask a quick question, if you don't mind? And that is, one of the things that we have been that we've observed in the management of so many types of lung cancer that are driven by a targetable mutation, for example, EGFR-based lung cancer, is that we recommend biopsy upon progression, because there are different mechanisms of resistance, and based on those mechanisms, we can determine the most appropriate therapy. It seems like that concept is not relevant, at least for management of second-line ALK rearranged lung cancer. Is that considered a true statement, or we don't know? And what are you guys doing?
So I think there's some data to support that they'll do better with subsequent TKIs if there is a resistance mechanism, and you can potentially target that. But lorlatinib does cross most of the resistance mechanisms, and so better than most of the other drugs. And so it becomes a little bit academic exercise rather than something that's really going to change your therapy at this moment in time. Patients with ALK also can transform, though, or could get MET amplification or other sources of resistance. So I think there are some cases, albeit rare, but if you don't look, you're not going to find them, and you may find alterations that may help give rational combinations. And so generally we start with liquid biopsy. If there's a really rapid progression and it looks like the biology may be changing, that's when we think about doing tissue biopsy and looking for transformation and things like that.
No, really important points. And actually, I brought up this slide actually just to kind of show some mechanisms of diverse co-alterations that can happen. Just for a reference sake, the diversity here may actually just jump to this, this question for both of you is, are there any clinical trials that you have at your respective institutes for the post lorlatinib space around mechanisms of resistance, whether they be bypass pathways or such?
So I agree with what Karen said on both the liquid biopsy, looking at resistant mechanism, and also the P53 adding chemo. You probably have to do it on a second line setting. So if you progress on your first line of TKI and you have a P53 mutation, maybe that's the time to do the trial versus chemo or something like that. We don't have any. Well, I mean, we have the Nuvalent compound, but they are also very smart. They designed the trial so that if you have any other actionable driver mutations, they will not enroll the patient. So if you have a MET amplification after lorlatinib or after alectinib, you are not eligible. So one of my colleagues has a very rare ALK fusion in bladder cancer and failed chemo. We redid the liquid biopsy, and now they have a tag-free FGFR fusions, plus a G12V on KRAS. So the patient does not qualify because any other actionable driver mutation that can serve as a bypass pathway is excluded, which is pretty smart, but also narrow their spectrum. But if you have a MET amplification, I would just add Cametinib, right? Cametinib is MET, yes. So that's how you just do it off label at this point, I think.
Okay. And And Dr. Wu, do you mind commenting a little bit about the nuvalent medicine? In what ways is it addressing unmet needs?
What the unmet needs is a double mutation. So if you have if you go sequential use of TKI, you'll get one mutation, and then after another, you get another mutation. And this drug preclinically is supposed to overcome compound mutation in cis, which is in the same DNA strand or allele. So that's their strength. So we shall see. But this will not overcome, let's say, a MET amplification, a histologic transformation as brought up by Karen, or anything, EGFR, there's so many things that can serve as a resistant, off-target resistant mutation that they will not be able to overcome. So that's the challenge of what they describe as threading the needle. I mean, you really don't have a needle to thread anymore if you have too late into the lines of therapy.
Yeah, no, really important points. And besides the nuvalent medicine, how are you thinking about some of the other inhibitors? Are there other ones that are worth, evaluating at this point? Repotrectinib, taletrectinib, other medicines?
Well, repo doesn't work as an ALK inhibitor because the fold difference as ALK activity versus ROS1 track is probably a 10 to 100 fold. So you're going to hit side effects before you can hit efficacy for ALK. Taletrectinib is not an ALK inhibitor, it's a ROS1 track. So nuvalent 655 is the only game in town right now. And then you have to use a more combinatory approach, chemo, anti-angiogenic agent, you name it. You probably have to do a combination approach.
Mm-hmm. So that's actually great segue into, just kind of vetting out the ROS1 space. And, I think, this slide actually just highlights a similar set of questions, but now for ROS1. I think one of the points is it appears that there has been a lot of interest with new medicines in the ROS1 space. Specifically, actually, as you've mentioned, the repotrectinib, nuvalent, 520. How do you view the ROS1 space changing? And current practice, how often are you using entrectinib versus crizotinib? And are you even using crizotinib anymore in this space?
I'll let Karen go first. I don't want to hog the Zoom.
Yeah, so I think, crizotinib is an excellent ROS1 inhibitor, and probably better ROS1 inhibitor than it is an ALK inhibitor or MET inhibitor. And so my experience with crizotinib has been very good. And even from the initial studies, we see prolonged progression-free survival in these patients with crizotinib, and even some brain penetration that may be a little better than what we see in ALK patients, but probably not better than some of the other newer generation inhibitors. So more recently, I have used more entrectinib up front, and again, because of the brain penetration, the tolerability, again, with some of the neurotrophic effects that the patients experience, there are definitely issues with entrectinib and the drugs that cover Entrec also. And so I will tell you, the weight gain is real and challenging. I had a patient gaining almost 1 pound a month, and they're on these drugs for long periods of time. And so we ended up having to dose reduce the patient. But I think both drugs are very good. And again, because of potential brain penetration, I've gone more toward entrectinib, and ROS1 is very uncommon. So it becomes hard to state, we don't have many patients that we're treating when you get down to ROS1 patients. And so it is hard to do the compare and contrast. But in general, at this moment in time, I've been using entrectinib.
And Karen, I may actually just extend on that point. This goes into the prior discussion as well about chemo, and how you've integrated chemo in different ways after progression on one of these inhibitors, whether it be for ALK or for ROS. In this context, in either the ALK or the ROS, are you continuing the TKI with the addition of chemo? Or do you kind of stop the TKI and then go on to chemo? How are you doing it in your practice?
So I tend to only continue the TKI if there are known brain metastases, not if there are not. Rather than, because I do believe that we can kill off resistant cells and potentially go back to some of these TKIs. And so I'd rather, if the patient can come off of it, I would rather have them be off and get a complete holiday and try and remove that push for resistance to the TKI. But for patients who have known brain metastases, I generally keep the TKI on and do not remove it.
No, thank you for sharing your practice pattern there. Dr. Wu, your practice actually, do you continue the TKI or stop it there?
So I'll go back to the prior question. First, I agree completely with Karen. ROS1 is rare. It's actually maybe even rarer than RET. I agree that I've been sold by Roche. I use entrectinib. I have the dose reduced. I have 2 patients actively on entrectinib. I have the dose reduced to 400 because of the some dysgeusia, some dizziness, and all that. So both patients have entrectinib, had to go down to 400 twice a day. Even though we did our phase 1, we were phase 1, we thought it was pretty well tolerable was 600. TKI, I think with ALK being such a neurotrophic, kind of disease, I'd keep the TKI on. It's just for just feel better. That's basically what it is. The good thing about all the ALK TKI is there's really no myelosuppression. Unlike osimertinib, you see some neutropenia, some thrombocytopenia. So I keep the TKI for the one that has a higher neurotrophic tendency. So ALK ROS1, I just switch to a different TKI. I don't that's rare at this point. It's pretty rare. Like I said, I have 2 patients on entrectinib, they're doing pretty well, and so just see what happens.
And how do you view some of these newer medicines then, repotrectinib, Nuvalent? Do you see these superseding entrectinib?
It will take years if they do so. So that's first they need to be approved first. So let's just say whether they get approved first. And then they will have to show the PFS. I think eventually they will, but probably by the time LA Olympics 2028, World Cup 2026, I don't know. Your flight of LAX, so it's they're coming. So constructions.
Yeah, that's interesting. And I think one of the unique characteristics that these medicines are trying to position themselves with is around resistance with the G2032R. I guess the question is that a common resistance mechanism? And do you feel that the pathway forward for these medicines is around targeting resistance, or do you think there's a different strategy there for this?
Well, I think you asked very good questions. We don't know. I mean, we don't know what the resistance to first-line repo or first-line entrectinib is. And I think unlike all, G2032R seems to be the major resistant mutation. So you actually have a luxury here to use the first generation followed by second. Maybe I'll change my mind 5 years from now when they show the PFS of first-line repotrectinib or taletrectinib or the Nuvalent compound. But I think Karen brought it up very, very nicely. We don't see a lot of these patients. They're rare. So we don't spend a lot of time thinking. Even though we do trials, we don't think. I mean, we all think about EGFR and IO and all that. We seldom spend a lot of time thinking about ROS1. Okay, you know, there are free drugs. Hopefully they get approved, and then we'll use them when the time comes and the need comes.
Yeah. And here's just some data for repotrectinib. Again, treatment naive population had a 91% response rate, PFS almost 25 months. Here is in the TKI refractory patient population, looked across different mutations as well. In the G2032R, response rate of about 15%. Here is taletrectinib, another inhibitor that is being looked at, again, refractory patient population, the waterfall plot shown here, and, data about PFS after one prior ROS TKI, 14.2 months, after two prior ROS 1 TKIs, 4.1 month, and again, treatment naive, 29.1 months. Here's the waterfall plot in a refractory population. Some patients did have G2032R. So, I guess that, it seems like this is a pretty competitive space. Dr. Wu, I know you have a lot of experience, kind of with some of the trials here. How do you view, these agents vetting themselves against each other? Repotrectinib, taletrectinib, new valence medicine. Do you feel like we're going to be able to come up with a, kind of a winner take all kind of approach here, or is it going to be kind of just a repertoire of different medicines together?
So I'll take the liberty to speak quickly. I don't want to use a lot of time, but I think you need to show the side effects profile for the repotrectinib and all that. It's a very pure and the TrkB inhibitor, so you get the triad of dizziness, dysgeusia, and paresthesia. And so, as a frontline treatment, let's say the PFS is 30 months, and it's a lot of suffering for the patients if it's really true that the dysgeusia and all that. So maybe it's very good as a second line, because when you develop 2032R, that's the only option, so one of the two options. Taletrectinib is, I look at it as a 1.75G ROS1, so it's better. The side effects profile is less. It's not as strong as an NTRK inhibitor, especially TrkB of all the TrK. That's my prediction, but I mean, again, entrectinib, we all have to dose reduce. That means, this is, do we want to use it up front versus first line? I think it's a little bit different, but yeah, if you can in the future show a slide comparing the side effects, the dysgeusia, the dizziness, and the paresthesia, it's really mimic exactly what entrectinib is, because entrectinib is also a approved TrK inhibitor. So those are challenges that may preclude them from being a first line option at this point, or in the future, I should say.
No, that's super helpful, info, and I think really put into context how the side effects, can really, define selection pattern for the first line. I think that's also kind of reflection of the ALK space, and how we think about some of those components as well. But no, I think this is, it's been a whirlwind of different agents. I think one of the key takeaways is that, there are emerging agents in this space. Nuvalent 655 ALK is a novel ALK inhibitor, that can target some of the compound mutations. Resistance in that space is still kind of an area of further exploration, whether it be on target or bypass. ROS1, actually now several medicines being explored. Again, a rarer patient population, but some important considerations about CNS efficacy, resistance mutations, and toxicity considerations, and how we think those through. Obviously, I think one message that I took away from the discussion was, we need more models to think through some of the resistance. I think Dr. Wu, you had mentioned that we always kind of spend time on EGFR and others, but really kind of having the right models here, really important. So I may actually just ask, I know we have Dr. Vora and Dr. Jang on the call as well. Dr. Vora, Dr. Jang, I know, kind of in Dr. Vora specifically, we've kind of, discussed ALK a little bit, offline for some patients. Any questions that you guys have?
I was
gonna,
yeah.
Mhm.
If I could ask a question, it's actually the same question I asked you, Dr. Husain, a couple of days ago. So for Dr. Wu and Dr. Reckamp, I have a patient who was sent to me by the thoracic surgeon with unresectable stage 3 lung cancer. His disease was confined to his lung, obviously, and no distant disease on measurement. I was getting him ready for an approach where I went chemoradiation and then Durva in the consolidation space. And as I was doing the workup and getting the NGS, he came back with an ALK positive mutation. So I think the question became, do I treat this with targeted therapy, or do I sort of stick with the game plan of stage 3 lung cancer? Do you guys have experience in this, and what have you done?
So my first comment would be that you treat it like stage 3 because it's curable. And you use the TKI for future, because even though patients with ALK live a long time, they ultimately have tumor progression and need other therapies. And so you always go down the path of curing a patient, and chemoradiation is potentially curable. I'm not sold that these patients need a year of durvalumab, because we know that monotherapy, immunotherapy is really not so beneficial in patients with ALK and EGFR. For my EGFR patients, I don't use it, but with ALK, I'm not sure we're doing harm necessarily. With EGFR, you have the risk of higher risk of pneumonitis if you start osimertinib, but I don't think we have that same data for ALK inhibitors. So I'm not sure you're harming a patient, but you certainly may cause toxicity that outweighs the actual benefit in a patient with ALK or ROS1. So I would consider even potentially starting surveillance rather than durvalumab, but I would always do chemoradiation as my first step in these patients. And I've had patients who have progressed in the future, but not necessarily progressing in the chest, progressing in other places, and actually have been easier to treat when they have to go on their TKI. So I don't know what Dr. Wu thinks, but I'm very much in favor of going down the curative route and not pulling out the TKI first.
So I think I'll interpret the question a little bit differently. I think you're asking whether you should use durvalumab or actually an ALK inhibitor. And
I mean,
I would
the
use
real question.
So chemo RT, and then you want to go down the Pacific route, which is durvalumab, or you want to try the maintenance or with a TKI. I think that's what you're asking, right? You go chemo RT. Chemo RT is the standard. You can't be sued for doing that. And then the key is, should you use durvalumab, knowing that IO may not work in driver mutation positive lung cancer versus an ALK inhibitor. So I have recommended using ALK inhibitor as a maintenance. So you do chemo RT, I'll give you that. I'm not going, that's the standard. You do the standard. And then I think you do I actually will use an ALK inhibitor rather than durvalumab. Because I will ask the patient, we'll have a very intelligent discussion and say, do you think durvalumab will prolong or prevent CNS metastases in a disease that is already 3B? Probably not. And you can use markers to look at the CA if it drops at the very end of chemo RT. You can even do the fancier MRD test to see if, but you're always at risk at the CNS. So that's one, we just wrote an article, an editorial. An ALK inhibitor is a guardian of the CNS for ALK positive non-small cell lung cancer. Like, to word play on guardian of the galaxy.
So So Dr. Wu, can I ask a question based on what you just said? And that is, and maybe a more basic question than what Dr. Vora had mentioned, which is, will we ever have any evidence to support using an ALK inhibitor in the let's say in the maintenance setting for stage 3 lung cancer? By the same token, will we have data evaluating adjuvant ALK therapies following treatment of following lung resections for these patients? I have a patient right now with stage 1B lung cancer which is ALK mutated, and the question that's being posed to me is, should this patient be initiated on an adjuvant ALK inhibitor? And
or a neoadjuvant as well, actually, because I think
in this case, the patient's already been operated on. But yeah, I mean, these are the types of questions that, do we have studies that will be answering such questions, or should we be deciding based on kind of what you're thinking through right now?
So we can all learn from EGFR. So AstraZeneca has a LAURA trial, which is chemo-RT followed by osimertinib instead of development in EGFR positive lung cancer patients. I think that would be positive. I would definitely use TKI maintenance. I know this is outside. We've always been criticized. There's no data, but yet, by the time the data comes in, you have to use scientific, and it's a good judgment that I think I'll get TKI maintenance after chemo-RT. Let's just say after definitive treatment of the 3B disease, I would prefer TKI rather than the IO, especially if you look at Pacific, the EGFR subgroup did not benefit. As far as adjuvant, the adjuvant trial was not designed well. So it was alectinib versus 4 cycles of chemo. Data may read out. It's not like the Adura, which is chemo followed by, optional chemo followed by maintenance. So RET, fusion positive non-small cell lung cancer, there is a trial sponsored by Lilly, chemo plus or minus radiation, and then 3 years of selpercatinib versus 3 years of placebo, Libretto 432. Exact design as Adura. And I would imagine it would be positive because RET has a tendency to go to the CNS. So, and selpercatinib, I just reviewed a paper by Alex Strelon. I think it's already online. The 3-year cumulative incidence of CNS metastasis was 0 if you are baseline negative. It's already online in JTO. So TKI is guardian of the CNS, and if you have a driver mutation lung cancer that has a high tendency to go to the CNS, IO is not going to prevent from going to the CNS. TKI is the way. That's my rationale, and I'll tell the patient this is what I think. How long? Good question. Probably longer than 3 years, but that's just me. Hopefully, but it's food for thought. I mean, I think 10 years from now we'll be using TKI in this case, but at this point,
Turn on the shower.
it's all you have to use the best judgment. So
That's very helpful. Thank you.
Yeah.
I think we're reaching the end. And Dr. Husain, any last words before we wrap up? If not, thank you.
I just wanted to thank our panel and thank you, Dr. Lashkari, as well, for everything, and Dr. Reckamp and Dr. O, really, we really appreciated your insights. Dr. Vora and Dr. Jang, thank you for attending as well, and for all others who attended too, and
thank you so
really
much.
looking forward to the next.
Thank you so much, everyone. Yes, we'll see you next month. Bye-bye.
Thank you for the discussion.
Thank you,
Care.
doctors. Bye-bye.
Bye.